Today, we are discussing a topic that's close to the heart, literally, breast surgery. But we're not just talking about what's visible, we're uncovering the secrets of size, shape, and yes, even nipple aesthetics. That is an important component. We always say like the nipple's like the centerpiece of the breast, so very important to kind of consider things. Probably have some funny stories about that as well. So we're taking a deep dive into the art and science of creating beautiful breasts, and the smallest details can make the biggest difference. Whether it's fullness, symmetry, or getting that perfect lift, we've got answers to questions you might be too shy to ask, and you might just discover the key to unlocking your ideal self-image.
Welcome to The Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Graper Harper Cosmetic Surgery in Charlotte, North Carolina, The Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper, Dr. Robert Graper, and Dr. Evan Zug, also known as The Doc Dudes.
Welcome to episode 14 of The Doc Dudes. Best breast solutions, size, shape, and what about the nipple? Like question mark. I should have been like, what about the nipple? All right. I am Dr. Garrett Harper at Graper Harper Cosmetic Surgery. I am sitting around a table with two of the other plastic surgeons here, Dr. Evan Zug. Evan, say hello.
What's going on?
Evan's going to have a lot to say tonight. We're going to start drilling him. And then Dr. Robert Graper. Say hello, Dr. Robert Graper.
I'd like to say that we never sit around and talk about breasts, but we do.
True. Today we are going to talk about the best breast solutions, right? And breasts are one of these things where we talk about all the time. You've probably heard in other podcasts, or if you've ever been here for a consultation with regards to your breasts, we say, we are not the breast police, right? So yes, we have ideas, and different cultures have different ideas of what's beautiful, and there certainly are trends, right? I told patients today in consultations, the size implants that we are using now, I think nationally, statistically, they can tell you is just going down, right? Like there's smaller implants now. I think as women start to look for a more athletic, kind of leaner, still want the fullness, we're able to use smaller implants. It's not the kind of Pam Anderson, although she looked great, right? It's not the Pam Anderson kind of looking figures that people are going for anymore. So everything's really slimming down. But we're going to discuss a couple of breast procedures, and I'm going to ask Dr. Evan Zug to kind of define these procedures, right? So, Evan, when somebody comes in and it says the consultation is for a breast augmentation, what does that mean to you? What should it mean to the patient?
Well, that typically means the patient wants a more youthful, usually larger appearing breast.
Okay.
So.
Yep. So an increase in volume is an augmentation, right? And so we do that two ways. Probably 99% of them, we use implants, and the other one, fat grafting, right? So
Yep.
Who's a good candidate for fat grafting? Somebody comes in and says, I'm an A cup, I want to be a D cup. Are they a good candidate for autologous fat transfer?
I typically talk to patients that I can increase your cup size by 1 cup size with fat grafting.
Right.
It'd be very difficult to go from an A to a D and still have all that fat survive and not have any problems.
Right. So because you got to worry about the fat surviving, I tell patients, if you do want to kind of go up multiple cup sizes, it's going to take multiple sessions, right? Mm-hmm. And so fat grafting, kind of define that for people. What does that entail? I mean, where do you get the fat? What's the
so
grafting
typically,
mean?
patients, if they have a little extra fat on their tummy, or it's typically on the tummy or sometimes the inner thighs, we can use that fat and do liposuction and process that fat, and then use that fat to augment and increase volume in wherever you need it, whether it's breasts or anywhere else.
Yeah, I think most people probably hear about Brazilian butt lifts, which is that, right? You just kind of liposuction, take every ounce of fat you can get somewhere, and then they just cram it into a rear end and like try to make a shapely rear end with that, which I always kind of tell people, I feel like fat is better served to really kind of minorly change areas that need a little bit of suppleness to them, right? Like I don't think it's and you can get great shape changes and it can look amazing on the table, but I joke around with people all the time. I'm like, if you're looking at before and afters from people's Instagram reels, physicians that are big BBL guys, and I've got a good friend who is in Miami, and I think probably does the best BBL work in the country.
BBL.
Brazilian butt lift.
Thank you.
Right? Unbelievable. Not the videos that women used to have in the early 2000s, but actual surgery where you're doing this liposuction and then adding it to the rear end.
And I think that's a trend too. I mean, I think women are not wanting that big BBL anymore. They want to be athletic and have some shape.
By Kardashians. Yeah. It's Olivia Dunn time now or whoever, right? But it's one of these things where I tell people, it's like we hear the Aesop's fable, or I don't know if it's an Aesop's fable, about like the three little pigs, right? And it's like, how do you want to build your house? Do you want to build your house out of straw, or you want to like take the time and do it correctly and do it with mortar and brick? And so, you can get a huge change, no pun intended, in your rear end by doing the proper exercises. And a lot of times people just stick to one squat and they're like, oh, I'm not building. And I'm like, your squat is building one of the three key muscles in your rear end. So a little off topic with that, but just that's what people think of with autologous fat transfer. And you don't want to go, throw in 500 cc's, even if the patient has it, even if they've got a ton of fat in other areas of their body and you can harvest it. Why can't you put 500 cc's of fat in somebody's breast when you can use a 500 cc implant? So why can't you use that much fat?
Well, we know that not all that fat survives.
Yeah.
So and you can run into some problems with fat necrosis, where it's this hard, lumpy area that can be difficult to make better and improve. So you want to be conservative with your fat grafting and only inject enough fat that's going to give a good result, but also avoid some of those problems.
Right, because just like skin grafts, any type of graft, a hair follicle graft, follicular grafts, those types of things, it is living off of neighboring blood supply cells, right? Because you've removed it from the body, so you've removed it from its blood supply. So now it has to bathe in kind of its neighboring cells. And so if you've got just a whole big mass, a big ball of fat that you put in there and you're not layering it in correctly, the center core of that isn't going to be in contact with anything nutritious and it's going to die and harden. And sometimes you got to go in there and cut it out. I mean, we've seen tons of people who have come from other areas of the country and even other countries that come back and had way too much done. And all of a sudden they've got firm areas in their breasts, and you can try to liposuction it to soften it. You can give it time and hope that the body enzymatically breaks it down, but sometimes it calcifies, and you got to make an incision on this patient and actually remove it. So it really can, if you try to do too much, can create a really big problem.
I mean, the hassles with fat grafting compared to the hassles with implants, the stability, the surety of the result.
Right.
For me, it's kind of a no-brainer.
It's a total no-brainer, but some people, right? And I blame social media. I think people who may think they're trying to help the public by bringing awareness to maybe their personal journey with breast implants that wasn't great. I think there's a lot of scare tactics in it because, we do thousands of implants a year for decades, right? Just in this room. And a very small percentage ever have a bad problem with, they
don't have health problems.
Right. And so it's like, somebody asked me, well, how many patients of yours have come back and had breast implant illness or something like that? And I can honestly say, I don't know of all of my breast patients through the years, I don't know that I've had one
exactly
that was my patient to begin with, right? I've had a couple of patients who came in and said, I've tried everything. I've got these symptoms and I just want my implants out, see if I feel better. And I think some of them feel better. And I can't tell you whether or not anything really changed biochemically in their
there is
body.
The placebo effect.
Yeah, or the placebo effect.
And there's no science that says they're going to feel better. But if they want them out, let's get them out.
Yeah.
But
these devices have been studied ad nauseum, and we now have 4 implant manufacturers that we're able to use in the United States. And by virtue of us only having 4 and other countries having 30, 40, 50 that they can choose from, I think should give you reassurance that the FDA and the science behind the studies has to be exhaustively done to favor these implants as completely safe, which they are.
I think they're completely safe, and I think the important question for patients to know is what's the reoperation rate, because there's a problem. They're too high, they're too low,
Right.
They deflate. Those things are really rare. The reoperation rate is mostly, I really like these, but I think I could go bigger.
Right.
And rarely, I think I went a little too aggressive.
Right. I
and
think
want
the
to be
data.
smaller.
I think the data shows that of people that get breast augmentation surgery, somewhere like 15% of those patients wished they had a different size. Of that 15%, 86% wish they went bigger and 14% wish they'd gone smaller. So, all right, that kind of defines augmentation implants versus using autologous fat transfer. Evan, what's a lift? When somebody says, I want a lift, what's that mean?
Yeah, so a lift is kind of similar to a reduction. It's typically after as the breast age, nipple position, the volume of the breast, the most projecting part of the breast is descended with time, and so you want to lift the breast and most importantly the nipple and the areola up to the most projecting part of the breast, and that's typically what we do with a lift.
Right.
And kind of with a lift, it's more the patients typically like the volume of the breast. They just want to have a more youthful looking breast. Some of those patients are my favorite patients in surgeries to do because you're really changing the shape of their breast. Right. Some patients just from bad genes will have a tuberous, long.
One thing that patients always ask, and they ask about it mainly when they come in for reductions, right? They say, I've just got enormous breasts, I need them to be smaller. Do I get a lift with my reduction? And so kind of define for patients, like what's the difference between a lift and a reduction? Is there a difference from a surgical standpoint? Is there a difference philosophically? Is there a difference? I mean, we're all trying to achieve the same goal ultimately, right? Things that you talked about, nipple position.
I'm going to lift the nipple and the areola into the right spot in a reduction. I'm not going to do a reduction and not pay attention to the aesthetics of the breast.
Right.
But typically with a reduction, with a lift, you're really trying to preserve the volume they have. And with a reduction,
you're definitely preserving the mass. Yeah. And I tell people that density is equal to mass over a volume. And they're looking at me like, whoa, nerd. And I'm like, I know that's like the only physics formula I remember. My son's doing physics right now. And I'm like, buddy, I can't help you.
But 1/2 mv squared.
Oh, that's a good one. Yeah. Well, I always remembered it because it was like DMV. And I could remember DMV. You know what I mean? So, but volume is the denominator on that bad boy. So we want a more dense breast, right? That's a more youthful, beautiful breast, better feeling. It just is. So if we don't change the mass, which is the numerator on that equation, the only way to get an increase in the density is to go down in volume. So I tell patients, because it's a really funny visual, and I like to try to get patients feeling comfortable and laughing in consultations because it's an awkward kind of scenario for them, and I'm sympathetic to that. I tell them, like, look, if you were leaning over the fish tank and put your breast in there and looked at how the water displaced, you're going to have less water displacement after your lift because we're going to have less volume to your breast. But from their vantage point, they look down and see the world through their eyes. So when they see a more projecting breast, a rounder breast, it can look larger to them because they're used to kind of seeing all that mass down.
Certainly the superior fullness is much more.
Which is what everybody wants, right? Everybody wants upper pole fullness. They want cleavage, or at least they want the ability to have cleavage in certain outfits. That's what a lot of patients say, right? All right, so a reduction, you get a lift, but you're actually removing mass from that. So with the lift, which is already going to reduce your volume, son, and the fact that you're taking mass away, you'll get a compensatory, even bigger decrease in the volume of the breast, right? Mm-hmm. And then reconstruction is stuff that Dr. Zug mainly does for the office. I still do it, did it for a long time and love it. Those are definitely my favorite patients, but Dr. Zug stays really busy with it. And that's after some removal for cancer or precancerous kind of conditions or just genetic susceptibility to cancer is kind of a prophylactic situation.
Yeah, so reconstruction can mean, after a lumpectomy, doing a breast reduction as well, or filling the defect from where the lumpectomy is. And then other times it can mean making a whole new breast out of nothing.
And so just so women that need reconstructive surgery feel better about things, like, do your goals for what you want their breast to look like in the end change at all when it's reconstruction versus a cosmetic procedure?
Well, yeah, they do. I mean, to a certain extent, I think one of the hardest things we do is get a feel from our patients and set expectations for them for what they're about to go through for breast reconstruction. And that's difficult to do.
Yeah.
And so, I mean, I try to tell patients that I want you to feel confident and comfortable in clothing after your breast reconstruction.
Sure. Yeah.
And anything else is icing on the cake.
Yeah. I think that, with the quality of breast surgeons that we work with here in Charlotte, I have gotten to the point where with my breast reconstruction patients, no matter who they are, no matter what their breasts look like preoperatively, I tell them, I want you to have full confidence that my goal is for you to look better on the back end of this than you do right now, right? Like, and can we reach that goal in every patient? I mean, no, sometimes factors come into play with radiation and things like that. But, as far as fullness to the breast, positioning of the breast, positioning of the nipple areolar complex, those types of things, it's not like we're just like, this is a reconstruction. It doesn't have to be exactly where it is. I mean, the day I say, in a surgery is the day I'm walking out. I'm done. I'm quitting. So
we really can get some amazing reconstructive
they
results.
Can look like cosmetic cases. I mean, we've posted a bunch of patients on social media and just been, Debbie with media and that has kind of kept us classy, but I feel like kind of posting something up there and being like, what procedure do you think this patient had? And just let them guess. And I promise you, there's no way some of these people are saying reconstruction. So, the goals, the aesthetic units of the breast are tried and true, right? Like sometimes when I'm taking measurements in patients, I'll tell them, oh my gosh, like you're a perfect equilateral triangle between these measuring places. Leonardo da Vinci would be so happy. You'd be perfect back then, just like you're perfect now. So what consistent qualities of the breast, I think, are things that we always try to strive for if we're doing an augmentation, a lift, a reduction, or a reconstruction. And so what's important is that everybody's different and body needs are different, patients' expectations are different, patients' goals are different. So one thing, we have used here before, and, Dr. Graper, I felt like somebody asked me the other day, and I was like, we just don't do it as much as the 3D analysis of the breast, right? Like where we can show you what your breast is going to look like, right? And I think that that can be a good tool for some patients, but it doesn't always get it right. It's still kind of animated looking. And so I have patients send wish pics, right? And when they send wish pics, that gives me more insight to what qualities of the breast they think are beautiful. If they're trying to tell me, I want more upper pole fullness. All right, well, where do we stop? Or they say, I want more cleavage, or I really love side boob. Or I don't love side. What does that mean? A picture's worth 1,000 words, and giving me some photos of a model or someone in a bikini. It's actually kind of funny. Sometimes people come in and they show you pictures of them when they were breastfeeding. They're like, this is when I love my breast. And you're like, oh, okay, great. And so that really helps guide us in the operating room because we're not having to go off a number in a letter that's a bra size that may or may not be correct. I'm daily floored by some people who come in and just are way off on their bra size or what, they're a C cup and they think they're a triple E because somebody tells them that. It's just frightening almost. All right, so one thing that is obviously critically important that patients understand is the limitations of their own anatomy. And so some of that is quality of their breast tissue, quality of their skin, but also positioning of their breasts, right? So talk to me a little bit, Dr. Graper, about the fold and where a fold is on somebody's chest. And the fold is their inframammary fold. It's the bottom part of the breast. If you lift your breast up or you look at it, it should be, hopefully, is kind of a round indentation area of adhesion to the breast where really the breast, I tell people, that's where the breast starts.
Exactly.
It's not from the top of the breast, but that's where the breast starts. So when somebody comes in and has a low fold, and then grabs their breasts and pushes them up and says, I want to have them underneath my collarbone. I mean, what do you tell patients?
Well, their anatomy is a limiting factor, and the breast is pretty based on where the nipple is compared to where that fold is.
The most critical aesthetic unit of the breast.
Then there are other, volume and how much convexity is medially laterally. There are some other things, but the number one thing is that nipple relationship to the fold, and as long as the nipple is above the fold, that's a good start.
Yeah. I mean, that's how we define ptosis, right, Evan?
Exactly.
I mean, literally we grade breast droopiness according to that relationship. So what's the difference between grade 1, grade 2, and grade 3 droopiness or ptosis? And for people who don't know how to spell that, it's actually PTOSIS if you're looking it up. But what's the difference between grade 1, grade 2, and grade 3?
Yeah, there's lots of different ways people define it, but typically, grade 1 is a centimeter or 2 below the fold, and grade 3 is going to be nipples more than 3 centimeters below the fold and pointing downward versus pointing forward.
I tell patients, if you put a pencil underneath your breast and you have normal posture, don't lean back, don't put your hands up, don't do anything crazy, which are some kind of gimmicks and things that plastic surgeons do for their post-operative photos to make it look like they've had a better lift than the patient actually had, was to have them reach to the sky. So we'll do another podcast on how a lot of plastic surgeons are kind of
adulter their
fibbing
pictures
and doctoring their pictures. But we used to say, if you put a pencil in your fold crease and you stand up with normal posture, if your nipple is above that pencil, you theoretically don't have standard ptosis or standard droopiness. If it's at the level, if your nipple is right at that level of the pencil, it's grade 1. If it's below the pencil, but not at the absolute bottom, you're grade 2. So that's how we kind of define some of those things. But I agree with Dr. Graper. I tell people your fold is like the foundation to your home, right? And so there is only, and then you got to worry about the width of their chest, right? Because you don't want to go wider than their chest can handle just to get more height to it, because the devices we use now are round devices. So, at least the devices I use. So, Evan, people come in and they talk about what's a gummy bear implant, what's a shaped device, what's a textured device. Just kind of briefly define those things for patients and tell them why maybe I only use the smooth round devices.
Implants have evolved over, the last 30 years, and we have 5th and 6th generation implants now, and they're more cohesive, they're softer feeling, and I don't ever use a shaped device or a textured device. There's rare instances of breast cancer associated with the textured devices, so most of us don't typically use those anymore, but there can be a role for them in certain patients. Patients will always ask about gummy bear implants, and it's really the same thing as a highly cohesive silicone implant. And it's basically, if you were to cut it in half, the implant is going to hold its shape. It's not going to leak out. A lot of patients think that if their implant ruptures, that silicone is going to leak out into their body and go all over their body. And that's really one of the biggest fears that patients have with silicone implants.
Sure.
And I try to.
And the older ones were a less viscous kind of gel, right? So when that happened, it could get kind of weird inside the pockets. We've all taken out 40, 50-year-old implants, and that's a different scenario than the ones now, and that's what I tell them. I say, the inside of a gummy bear implant is like a really nice, soft gummy bear straight off the Haribo or Black Forest line, not like the white ones that nobody eats that you find.
The Jolly Ranchers.
The Jolly Ranchers, none of those. It's not what they are, right? These are very soft and wonderful devices. And they actually make them in different levels of like cohesiveness, which is the gummy bear. So, and that, you make decisions based on the patient's anatomy and based on where you're placing the implant, either above or below the muscle, which is also kind of an entirely different topic and something that we're not going to necessarily discuss today. But
please talk to them about how much better the experience is going on top of the muscle compared to what it used to be.
Correct. And so, all right. Well, if you're going to bring it up, so I 5 years ago, I was 95% all my patients were below the muscle, and we just didn't have the devices that would maintain their upper pole fullness and their shape. And, but I mean, that's so evolved. We say under the muscle, but like we were under the muscle 20 years ago. And then we started developing this dual plane, which was like the top portion was under the muscle, but the bottom portion wasn't. Because we knew that the bottom part of the breast looked prettier when it was filled with the implant's volume. And that muscle, if you didn't divide it and get it out of the way from the lower portion of the breast, it was preventing the implant from going where it needed to go. So we've done so many different iterations of like what the standard for beautiful breasts was, that now we can just leave the muscle where God intended. And for the majority of patients, right, the patients that aren't great for this are patients that have lower folds, that potentially have thinner body habituses. And so for those patients, it's nice to have it underneath the muscle to help transition a long chest. But for 95% of patients, I just think it's a more natural and beautiful look to have an appropriate implant that fits the patient's size, their body habitus, to be above the muscle. And I do think it's an easier recovery. I just don't think we have the issues that used to be reported as far as capsular contracture or any of those problems, certainly that we had with saline devices, but also with the older gels. I think where you get into trouble is, not using a funnel, not using the inframammary fold as your access point, too large of an implant, all those types of things. Nipple shields, all those things, I think are critically important to reduce your risk of having problems. And I think we've done a really, I'm going to say a really damn good job of minimizing that, right? And I still have patients that have capsular contracture. It happens, but
not many.
But I have patients because I've got thousands of them. So if you got 3 or 4,
it used to be 20%.
Yeah, you got to take it into consideration.
If you were honest, it was 20%.
Right,
People say, I had 5, and I'm looking, going, no way.
Right. Well, we got to the point where we never put salines on top of the muscle because we knew for a fact that the water hammering effect was just going to cause a problem for that, So, Evan, you've already talked about like nipple position, right? You want the nipple at the most projecting part of the breast. What about like size of the nipple areolar complex? I think sometimes people talk about nipples, and you can have nipple issues, right? Some people have really long, big nipples, and they want a nipple reduction, and we do that. I know that sounds crazy to some people out there, but that's a real thing. Conversely, we have patients that have really small nipples, and sometimes we need to augment the actual nipple with either filler or something like that. But, it's one of these things where when we talk about the areola, what's the right size for an areola? Is there a right size? Is it, up to the patient? Beauty's in the eye of the beholder. I do know I had a patient, she's not listening, but it was a couple of years ago, and she came and she had large areolas. I mean, large. And so I was kind of talking to her about like, oh, this is going to be great because, with a lift, we're able to reduce your areola diameter, and like, that'll be really great for you, And she's like, oh no, like that, my husband loves my larger areolas. And I was like, I don't get a say in this. And I don't, ultimately because we do what the patient wants, but, is there a normal range for an areola? And obviously the diameter of an areola is going to be different on a 5', 95 pound, really tiny person as opposed to somebody who's 6 foot with a broad chest and, 200 pounds. So those are going to be different breasts, right? And so, but is there kind of a normal range for nipple areolar complexes?
I mean, yeah, you want to choose what size that fits the patient's breast size,
right,
and body frame. But I mean, I typically use a 42 millimeter cookie cutter. They kind of range from 38 to 42, and I've done all of them. But I personally think that's an attractive size for an areola.
Yeah. And if somebody has like a real kind of off way from normal, divergent kind of areolar size already, I mean, if it's too small, you can't make it bigger. So you just kind of tell patients it is what it is. I mean, they can go get tattooing and things like that to try to camouflage it and change it. But from a getting smaller standpoint, I just kind of say, because some people ask, and I'm like, well, here's the average. And I bring out the ruler, and I'm like, it's going to be somewhere between 39 millimeters and 49 millimeters, depending upon how large your breast is. where that is, I'll say, if you really feel strongly about it, why don't you bring me a photo of what you think is pretty? And so in that point, I try to tell people, I don't, when you're showing me pictures or sending me pictures, just send me a bikini photo or something like that. But if somebody really has questions about a nipple areolar complex, I'm like, just give me an example. Find me something where you're like, this is good, because man, you can be thrown off in both directions, right? Some people want really small areolas and some people want large areolas, but the position of it shouldn't change. And aesthetically, the most important component is its relationship to the fold, 100%. So I hope that we've gone over a lot. I feel like we've talked ad nauseum about breasts. So I hope we've answered a lot of questions for the audience. If you have any questions, all three of the plastic surgeons here at Graper Harper Cosmetic Surgery do breast surgery, and I think do it wonderfully. So come in for a consultation, and we can specifically talk about your goals and what we would do to reach those, and what our kind of philosophy is. But if you've got questions or topics you'd like for us to cover, please visit ghsurgery.com and click on the Doc Dudes from the homepage. There's a link to click to submit your questions and ideas. You can also listen to all of the Doc Dude episodes, 1 through 13, prior to this one, which is 14, on our website, as well as Apple, Spotify, YouTube, or anywhere you listen to your favorite podcast. Tell your friends about it. Anybody that has any questions about plastic surgery or the world of cosmetics, because that's what we're here to try to teach you and hopefully entertain a little bit as well. Follow us on Instagram and Facebook to find out when new episodes drop and other information about our practice. I'd like to say thank you to Dr. Evan Zug. Thank you, Evan.
Yep.
I'd like to say thank you to Dr. Bob Graper.
You're welcome, dude.
You're welcome, dude. And this is Dr. Garrett Harper signing out from the Doc Dudes podcast. Thanks, guys.